All right, everyone. I'm going to call this series because I'm going to do a few other videos literally all about like crazy things that have happened on my call that I want you guys to learn from because I have had some calls that have been a real big doozy. So I'm going to go through, this is just one of the things we're going to talk about LVADs and cardiac arrest, which these patients should go to a cardiac facility. They should go where they got their LVAD, but we all know life happens, things happen, and you never know when your hospital, your little suburbia hospital, might drop somebody off that has an LVAD. And what the heck do you do? So that's what we're going to talk about today. Plus, it'll be a good review on like kind of preload and afterload stuff. All right. So first of all, like patients have LVADs usually either for bridge therapy to bridge them to a transplant. Sometimes it's destination therapy. This is as good as it's going to get for them. And a lot of times they might have an ICD in place as well. So just something to pay attention to. But essentially, how does an LVAD work? So essentially, it's connected. So this is inside the body here, and this is outside the body. Because to understand what to do in arrest, altered mental status situations, we got to understand kind of these like basic things. So blood is going to enter the device from the LV. It's pumped to central aortic circulation, right? And they have like kind of this outflow cannula anastomose to the ascending aorta above the AV valve. Okay, as you can see in my drawing here. Okay, perfect, right? So in the body, that's connected to a motor, and that's turning like this impeller, rotating at this high speed, which is going to pump, basically move blood forward. This is going to be your flow, which is crucial to know. Okay, so this is the motor or the pump that generates flow, and this is set via the team. You've got pump speed per minute, which is usually set by the VAD team before you even will see this thing. Okay. Then, so that's pumping out to the body, that's your flow. Then you have this drive line, which I believe is kind of sub-Q, but it comes out to the body is the drive line. And then the drive line kind of connects the pump to the outside, and it holds important electrical wires and things like that. Okay. Then we have your controller, which is kind of the pack that you'll see them having. They'll have this pack. That's essentially the computer of the LVAD that has all the settings, everything. It'll tell you the alarms, and that operates essentially the pump, the motor inside, tells what to do. Okay. And then they usually will have like battery packs, right? So LVAD patients, they should know to always have their charger with them, to always have spare batteries. That's kind of one of the first thing to check is a battery issue. Okay. They always need to have those with you. All right. So LVADs are, I want you guys to remember a couple of things here. LVADs are preload dependent. Okay. And they really rely on having a good right ventricle function. I want you to think the fill and flow, right? Our RV function is good because we're preload dependent, right? And our preload is coming back in, right? Into the right atrium, into the RV. Fill, we need to fill, we need volume, and then we need to flow it out, okay? And flow is going to be dependent on our preload, our afterload, and our contractility, okay? And how you know flow is good in these patients, because they're not going to present like everybody else, is they're going to have a map via Doppler, okay, because you can't get regular blood pressures with them, greater than 60, and an end-tidal CO2 greater than 35 to 40, okay? That's going to be a lot of your criteria you're going to be looking for in these patients. So they're not going to have palpable pulses. They're essentially going to be in this like pseudo PEA, okay? Non-invasive blood pressures are about 50% accurate. Getting a pulse ox and an O2, not really reliable indicator of flow or perfusion. So your pulse ox is not really going to give you a true picture on if they're hypoxic or not. Okay. All right, guys. So that is how your LVAD is working. So what do? You have a patient coming. They're like, look, this patient was found down. They're an LVAD. And you're like, why the heck are you coming here? You're the closest one. This is where we're coming. And you're like, okay. And then they call you because you're anesthesia and you're supposed to be the expert. Okay. You are the expert. All right. So number one thing is as soon as they get there, get somebody to call the LVAD team. They should have a card There should be someone in your area. Get the secretary on it. Someone needs to be calling I'm trying to think, like they should, there's like a 24-hour 7. The family should have the card information. LVAD team, get that person on the phone immediately. And family is always going to be a good source of information because they had to go through a lot of education and stuff for this. So family, get on the phone with that LVAD coordinator ASAP. Okay. And then I want you guys to remember math less than 60, less than 50, and end tidal CO2, especially less than 20, drop below that 30 mark. That's when you really start thinking, what the heck is going on? But you're also like, what the heck do I do? Okay. So number one, you do what you do for everybody. Ventilation. Are they ventilating okay? Are they taking agonal breaths, right? Do they need to be intubated? Is this like a respiratory thing going on? What is their temperature of their skin? Do they have any cap refill, right? You're really going to be relying on these type of assessments pieces because you can't just throw on a blood pressure cuff and a pulse ox and find stuff. You got to use your other assessment skills. So temperature of their skin. What is their skin color? Do they have cap refill less than 3 seconds? Altered mental status, right? And then altered mental status, like that's going to lead you through to thinking other things. Could this be a stroke? Could this be maybe possible their blood sugar is low, right? You're always going to be running your H and T's, all right? I always tell people in their interviews, when you're interviewing for CRNA school, H's and T's always, that never changes, okay? So you're kind of going down that route of potentially what could it be? Blood sugar, hypoxia, stroke, maybe an overdose. Okay. So you're kind of thinking of those things. And then what is their rhythm, right? Looking at what their rhythm is. Do they have an ICD? Do you think, have they been shocked? Do you think that you witnessed a shock or anything like that, right? And assessing that rhythm from there. Okay. So that's your first thing, is that overall assessment. Then you should have somebody on that VAD. Is that VAD working? This is why you're going to get on the phone with that clinical coordinator, the VAD coordinator, ASAP. Is the VAD working? First of all, is there any alarms going off? We'll talk about a low flow alarm in a second. Are there any alarms going off? Second thing, auscultate. You can hear the hum. Do you hear that LVAD hum, or does it sound kind of funny? Get online, see what that hum sounds like, so you know if it sounds different, right? But are you hearing that hum, or is there literally like nothing? And then looking at, is the batteries dead? Is the drive line disconnected? Is the controller damaged? Does it need to be plugged in? Like all of those kind of basic things we do, right? Is like, need to be rebooted. What is going on, right? So looking at all those things concurrently while you're also doing your assessment of all these other things. Because remember, guys, these patients cannot increase their cardiac output. So when their afterload or their SVR has dropped, maybe they're septic, right? Are they septic? Do they have low flow? We're going to talk about low flow a little bit now. And low flow is anything less than 2.5 liters a minute. So if they're having a low flow, okay, they cannot increase their cardiac output. They can't do it, okay? Even if their device is performing fine, they still don't have that ability, right? And these pumps are afterload sensitive. So they will increase afterload to a point. But you're still going to see that low flow. And that's when you're kind of thinking, okay, maybe this patient needs volume, right? Now you're looking at like, what does this patient need? Maybe they need a little bit of volume, okay? And another thing to keep in mind, these patients do have some native residual heart function. Some do, I don't say all of them. Some of them will have native heart function that might circulate blood for a little bit should the LVAD stop. But some people are completely dependent on the LVAD, and they're like AV valve is like completely oversewn. Like they couldn't even use their heart if they wanted to. They're completely dependent on it. So just keep that in mind. Sometimes you might be able to see a little bit of native heart function come through. Some of them might not have any, okay? So H's and T's, going through all the things, especially if you see like a low flow alarm, hypovolemia, are they bleeding, right? Are they hemorrhaging somewhere? What is the source? What is their INR, right? What is their, their clotting levels? What is their H&H, especially what's their crit, right? What are we looking at here? Tamponade, pulmonary embolism, pneumothorax. Has there been some type of trauma to them, right? You're still going through all of those things. And remember, like I said earlier, RV dysfunction. If they've got RV dysfunction, they are going to struggle, okay? So being able to kind of go through those and start treating and going through all the algorithms that we know. Getting an A-line in if possible. And once again, you've already been Dopplering too. Are you Dopplering? Do you see an actual like flow through like an artery, femoral, brachial, whatever. Like, are you Dopplering those pulses? Are they there? You can throw an A line in, and really an echo is like invaluable. I mean, the main thing is like getting your LVAD team in, getting them on, ECMO or something like that. But being able to do a TE or something, or even, something just to kind of see the chambers, like what the heck is going on inside, is crucial if you can possibly do that, depending on the severity of the situation. And then there's a lot of controversial about chest compressions because they can cause dislodgement of the device, or they can cause like aorta back to LV kind of regurg, like it goes backwards. But if, you know, your map is less than 50, you're not seeing any flow, low flow, no flow, right? You're seeing none, and your untitle is low. It's time to, look at that rhythm, defibrillate, start compressions. Now, they do say to not use any type of automated chest compression device, and it's still probably super controversial. But if you are up a creek without a paddle, you got to do what you got to do, right? While you're trying to treat the other things, such as the hypoxia, hypoglycemia. Did they have a stroke? Is there like a giant thrombus in the pump itself? Because that can happen too and cause decreased flow. Um, Infection, bleeding, is there a GI bleed potentially? You know what I mean? Like looking at all these things. And then if all else fails, defibrillation, if applicable, CPR, getting volume on board, getting blood on board, and even thinking about getting some pressors on board as well. Okay. All right, y'all. So I hope that helped a little bit to drive a few points home. If you are ever in, unfortunately, I hope you're never in this situation, but if you're ever in this situation, at least you kind of have something to kind of go by if this happens. Plus, it's a great review for those of you, prepping for your interviews or even in anesthesia school. If you guys have any questions about this, let me know. And don't worry, I got lots more coming your way on things that have happened to me in call that I didn't prepare for in school, because you can't prepare for anything. But what you can do and what you should do every single day, what I want you to every single day, is just show up and squeeze the life out of how much you can learn. Because once you get your foundational info set, and you can, induce, you can look for differential diagnoses, you can figure out how your treatments and everything, that once you got that set, you can literally handle and do everything. And people at the hospital are going to be looking to you as a leader to be able to handle and do things. And you will be able to, as long as you keep on showing up and doing your best in that capacity of that day every single time you go into clinical. Okay, guys, need anything, you know where to find me.